Thank you so much for that nice introduction and for inviting me to this beautiful medical center. It makes our places in New York look, well, not so beautiful. Although this view is, if you go to the roof of the Guggenheim Pavilion, which is the main hospital at Mount Sinai, this is the view you get of the reservoir in Central Park and the west side and the east side. And I live somewhere in this area there. So anyway, I'm going to be talking about a condition that you all think is rare, I'm sure. It happens that my practice has turned into this disease, and let me just tell you a little bit about it. I don't really have any financial disclosures because there are no drugs that are used to treat this disease and no devices that are used. So unfortunately, no one supports me externally. In 2009, about the year we started the United States Registry for Fibromuscular Dysplasia, Tom Burton got interested in this primarily through Pam Mace, this woman on the left here. She's a registered nurse from Cleveland. Tom Burton won the Pulitzer Prize for his work on abdominal aortic aneurysms. And it was really fascinating working with him on this. And he actually got this article on the front page of the Wall Street Journal. This article did more to increase awareness of fibromuscular dysplasia than anything I'd ever previously written, including a major article in the New England Journal of Medicine. After we published that article, nothing happened. After this was published, within minutes of its publication, I was getting emails from Australia, South Africa, all over the world of people who thought they had fibromuscular dysplasia. Pam is a registered nurse. She went to an emergency room in Cleveland 3 times with symptoms of a hemispheric TIA. 3 times she was sent home and told she was crazy. She's anxious, get a life. She then came to the Cleveland Clinic, where I was at the time, although I did not see her at that time. And Jay Yadoff, who published probably the first paper on carotid stenting for atherosclerosis, actually stented her carotid arteries. This is all known information, no HIPAA violation here. And she had had bilateral carotid dissections and severe FMD of the renal arteries with blood pressures at 250/150. Since that time, she has been a staunch supporter of increasing awareness of fibromuscular dysplasia, and is the executive director of the Fibromuscular Dysplasia Society of America, of which she does for nothing. She receives no monies for that. The woman on the right is from Toronto, Canada. Her name is Rochelle de Rocher. She also is involved in the Fibromuscular Dysplasia Society of America. She had severe renal vascular hypertension. She read about FMD and had a few papers that I had written, but I had not met her. And her nephrologist sent her to an interventional radiologist. She brought papers that we wrote and gave it to the interventional radiologist. And the interventional radiologist said, I've done hundreds of these cases, took the papers and threw them in the trash can right in front of her, allegedly. And she somehow let him go ahead and do her renal artery. He dissected the renal artery. She lost 60% of her kidney. She was in the hospital for 8 weeks and developed severe post-traumatic stress disorder. So it's stories like this that have made it where patients have taken back their own health care. The patients are the ones who reach out and find people who are experts with this particular disease. Now, if there's any radiologists in the audience, I do not mean this to be insulting, but this is what we see. And as I was discussing earlier, I meet with our neuroradiologists every 6 months, our body radiologists, we work in the same room, and to try to get everybody up to date clinically. But whenever it's really not clear what's going on, in the radiological diagnosis, it always comes up as possible vasculitis or possible fibromuscular dysplasia or vasculitis. Clinical correlation is suggested. Or there's a dissection in the renal artery and a renal infarct. Thrombus is present, vasculitis needs to be excluded. There's a new dissection of the left internal carotid artery. The right internal carotid artery is aneurysmal, as is the left distal vertebral artery. This is highly suggestive of vasculitis. None of these scenarios are suggestive of any vasculitis that I take care of, and I take care of a lot of large vessel vasculitis, such as Takayasu's and giant cell. So why is it that we have to be told to clinically correlate a test that we order for a particular reason? So I teach my fellows, and we have a multidisciplinary reading room where we all work together, because it's not in the patient's best interest to just accept the official interpretation of a study, but to be able to look at these images yourself and determine if, in fact, a disease that you're seeing the patient for is actually consistent with what you're seeing radiologically. So this is what my practice has become. 50% of the people referred to me or who come to me on their own for FMD fibromuscular dysplasia don't have it. Many of these patients go on a Facebook page where they're given information that is not correct. 20 to 40% of women with myocardial infarctions from spontaneous coronary artery dissection are not correctly diagnosed. They're told they have a blockage, but they're not told that they have SCAD. So my practice has kind of turned into FMD-like, SCAD, large vessel vasculitis, and then maybe 5 or 10% have what most vascular doctors take care of: peripheral artery disease, DVT, pulmonary embolism, lymphedema, and swollen legs. So for me, these are the uncommon diseases. These are the diseases I see. And mainly I see them not because doctors refer them to me, but because patients go online, they look up their symptoms and see what they have. And if they can afford to travel to New York, then they travel to New York, or they travel to Cleveland, or hopefully they'll travel to your medical center when you're part of the FMD registry. This is a paper that we published in JACC a few years ago, which just shows the many different faces of fibromuscular dysplasia. I'm going to show you images a little better than this. This is the most common type, the string of beads type in the carotid artery. This is what's called focal FMD. I'll come back to that in a minute. This is arterial tortuosity. This is a carotid dissection with a pseudoaneurysm, spontaneous coronary artery dissection, and then 3 different examples of aneurysms. So when I was a fellow, I think you heard that initially I was trained as a nephrologist and hypertension expert. And I was taught that this occurred in women between the ages of 20 and 35 or so. All of this information that I was taught, and I was taught by one of the world leaders in this, actually ends up not being correct. This is typical string of beads fibromuscular dysplasia, or what's now called multifocal fibromuscular dysplasia, whereas atherosclerosis occurs in the origin of the renal artery or the origin of the internal carotid artery. FMD occurs in the mid and distal portions of the artery, whereas atherosclerosis does not. So in the last decade or so, the 2 major documents that have come out on this, the first was the AHA scientific statement on the state of the science and critical unanswered questions, which we published in 2014. And this is the international consensus document, because we've now collaborated with the group in Belgium, London, Paris, Poland, virtually all over the world, to come up with an international consensus on the diagnosis and management of fibromuscular dysplasia. Now, you will note that many of these authors are also well known in the SCAD literature. For example, David Adlam from London is well known because these 2 diseases, SCAD and FMD, are probably going to end up being the same condition. When I was a fellow, this is the classification of fibromuscular dysplasia, because there was no endovascular therapy then. The most common type, the string of beads type, was called medial fibroplasia. And these were all diagnosed histopathologically, whereas now we rarely get histopathological information because everything is taken care of with a catheter. So the string of beads type is called multifocal, and the focal type is called focal, and that previously had been called intimal fibroplasia. So here's an example, carotid arteries of multifocal FMD. Again, whereas atherosclerosis occurs at the carotid bifurcation, this occurs up by the ear and more distally. And this is an example of the string of beads type in the external iliac artery. Why it occurs in the external iliac artery and not the common iliac artery, I have no idea, but this is a very common location for it. And now that more and more cardiac catheterizations are done through the radial artery, we're encountering brachial artery fibromuscular dysplasia, which can easily be diagnosed on duplex ultrasound where you see this string of beads. This woman came to me, I don't know, about at least 15 or more years ago. This is not her images from when she first presented, but she presented with a transient ischemic attack in the mid-1970s, and she brought with her catheter-based angiograms on film. And this is an MRI demonstrating her carotid arteries 40 years later, and there's absolutely no change in the appearance. This is a non-progressive disease. The beading you see at the time of diagnosis is the beading that is present. We have never yet seen a case where a patient goes on to develop beads in an area that no longer exists. There are other manifestations they can develop, such as aneurysms and dissections, and we'll get into that shortly. Now, what about this? We see 4 or 5 cases of this year. I think most people would say this is fibromuscular dysplasia. But the difference between what I just showed you and this is these oscillations are regular. This is what's called standing waves or stationary waves, and this is catheter-induced spasm of the artery. It can mimic fibromuscular dysplasia. If you're not sure, most interventionalists are sure, but if you're not, you just give a little nitroglycerin and the artery returns to normal. Or you can look at a CT angiogram that was done before the catheter procedure and you'll see normal carotid arteries. Yet here you see beading present, which is really not beading, it's really oscillations in the artery. So multifocal FMD, string of beads, balloon catheter, post-angioplasty. There is no reason to stent these. Stenting actually causes harm, and I may get into a little bit of this later, but this can easily be taken care of with balloon angioplasty. I'm not going to talk about the technical aspects of it, but there should be pressure gradients measured before and after your angioplasty. Now, this lesion on the left is focal fibromuscular dysplasia. This occurs in young men or women, whereas multifocal is pretty much women, 95%. But this can occur in men and women. And if you get this diagnosis early after their hypertension started, you do a balloon dilatation and you cure their blood pressure. I'll show you a case of this a little later. This was a 59-year-old male who came to see me, and I've seen 3 cases of this year, who has this lesion in his renal arteries. This is also focal FMD. This is a tubular narrowing. He had onset of hypertension for 5 months. He was told to leave this alone by another major medical center in New York because the CORAL trial was a negative trial for renal artery stenting. But that was a trial on atherosclerosis. This is focal FMD. He already lost some volume in this kidney. If we didn't do anything with this, he would have lost the kidney. And so a stent was placed with this type of FMD. And when we looked at his carotid arteries, we can see here, this is the so-called S curve. I'll talk a little bit about this shortly. This is extreme tortuosity that occurs in the carotid arteries. Now, if you do a carotid ultrasound and you just look at the bifurcation, you're going to miss this. because this lesion is up high. It's up in the mid to upper part of the ear. You have to angle your transducer very high to see this tortuosity that's present. Now, one of my colleagues and friends tell me, like, all I do is provide psychological support for my patients since there's no cure for FMD. Well, she's kind of right, but this patient doesn't agree with her. Dear Dr. Olin, thank you for curing my FMD. She had this focal lesion in a branch renal artery, really severe hypertension. And as a thanks, she brought me this beautiful vase, which I keep in my living room at all times. She came from Seattle, Washington. Why does someone from Seattle, Washington need to come to New York to have their FMD taken care of? Because people don't recognize this disease for what it is. Now, I just want to bring up one other condition that is often called FMD, but it's really not. This is a carotid web. And you'll see in the literature that some people call this FMD. This has a very high rate of stroke. It occurs proximally where FMD occurs up here. And the only reason I'm mentioning this is because there are papers in journals like Circulation and Stroke that say fibromuscular dysplasia in Afro-Caribbeans. And what they're talking about is this carotid web thing. For reasons that are unclear, it has a very high rate of stroke. She embolized to her middle cerebral artery here. And this was taken care of by our neurointerventionalists. And then she had the proximal portion of her carotid artery stented, and she did well. But even in 2000, this paper was written, embolic stroke of undetermined source and symptomatic non-carotid disease, in arguably a very, very good American Heart Association journal, with 3 clear examples of carotid webs, yet the authors did not recognize them as carotid webs. And we wrote this letter to the editor stressing the point that those lesions shown in those 3 figures actually were not atherosclerosis, but they're the so-called carotid web, and they need to be treated somewhat differently than that. So in 2004, my fellow and I wrote this paper for New England Journal of Medicine. Now, I thought everything in the New England Journal of Medicine is true, accurate, you know, it's the Bible, right? So we had this table, and we said that renal artery involvement occurred in 60 to 75%, bilateral disease in 35%, carotid disease in 25 or 30%, and multiple vascular disease in 28%. In fact, yes, 70% have renal artery disease. 70% or more have carotid or vertebral disease. And a much higher number than 28% have multiple vascular beds. Why did we say this? It was a review article. We wrote what every other paper said before this. And this is why you shouldn't believe everything that you read, because there's always ongoing knowledge. This table, entire table, is incorrect. Published arguably in the best clinical journal that you can get published in. Now, how common is this? This is really common. Okay, here's an example of 3,000 potential kidney donors. Everybody gets an angiogram or an MRA or a CTA, and 4% of them have fibromuscular dysplasia. What about this? This is the CORAL trial. The CORAL trial was an NIH-sponsored trial comparing stenting for atherosclerotic renal artery stenosis versus maximal medical therapy. An exclusion for this trial was fibromuscular dysplasia. So you randomize the patient on the table. They're randomized to either stenting or not. And it ends up being a negative trial. But when these images were sent to the core lab at the University of Michigan, University of Virginia by Alan Matsumoto, it ends up that 9% of the women in this trial also had fibromuscular dysplasia. This is a study that was supposed to exclude patients with fibromuscular dysplasia. Yes, they also had atherosclerosis, but they had fibromuscular dysplasia. We run a genetic study where every patient entered brings a friend of theirs to be a control patient. If they're female, they bring a female of the same age or within a couple of years of their age who are apparently healthy. We interview every control patient. We listen to their neck. We listen to their belly. We've now diagnosed FMD in about 8 patients who were brought in to be controls. And I could tell you other stories, such as a woman I saw last week at age 75 sent to me for atherosclerotic carotid disease. When we did the ultrasound in my lab, we looked very high up and she had fibromuscular dysplasia. So we are missing a lot of this. And the reason why it's important to diagnose it, I'll get into momentarily. Many doctors don't listen to the neck. When they do, they don't listen in the right spot. You're going to pick up arch disease here. If you want to pick up disease from fibromuscular dysplasia, you have to be at the angle of the jaw. You ask the patient to stop breathing, not take a deep breath in. And this patient had pulsatile tinnitus for years, being followed by a cardiologist. No one ever listened to her neck. This is focal FMD. In 2012, we published the first paper from the United States Registry for FMD on 447 patients. We now have 4,400 patients in the registry, and we're getting ready to update our data on this. And basically, everything I learned about this disease was wrong. The mean age at diagnosis of FMD was age 52, with a range at the time, age 5 to 83. We've excluded pediatric patients from the registry. Now it's 95% are female. It appears to be a disease of Caucasians, but this is bias. This is selection bias. I have patients of all ethnic backgrounds, and the reason why it's biased is patients who are educated and have the means to travel, and most of the African Americans, Hispanics, Asians, and others that I see are educated people who are willing to travel to find out what's wrong with them. But I don't think this is a disease of white people only. These are the big 4 presenting symptoms: hypertension, headache, usually of the migraine type, pulsatile tinnitus, a swooshing or a whooshing sound in the ear, and dizziness, and then bruits, aneurysms, dissections. We showed in this study, this was published in Cerebral Vascular Disease in 2018, that this is a non-progressive disease. No patient had beating present in an area where it wasn't present on the initial imaging. No patient who did not have an aneurysm to begin with developed an aneurysm. There were 3 patients who developed a dissection when we were following them, and 2 of those 3 patients had a dissection previously. So I tell patients what you see is what you get for the most part. There is a small risk of a dissection developing at some time in the future. Pulsatile tinnitus occurs in 25 to 30% of people with FMD, and they tell their doctors about this. And usually it's poo-pooed. We put a course on for FMD patients, and the ones who have really severe pulsatile tinnitus hear is a swooshing sound. They actually record it on their cell phones. They put it up to their neck and they play it back to their doctors. And this woman who started this website on people with tinnitus actually came to me to see if she had FMD. She does not. But she started this incredible website, which gives you more information about tinnitus than you ever want to know. And I refer a lot of my patients to this particular site. And then smaller numbers of patients have TIAs, strokes, renal artery dissections. This information is totally wrong, as I'll show you in a minute. So there are 2 distinct types. This is from the group in Paris, who we've collaborated with for years now. There's the focal type and the multifocal type. The age at the diagnosis of hypertension in the focal type is age 26. The average age of the diagnosis of FMD is 30. 90% of these people get intervention. and their blood pressures are cured in the large majority on no blood pressure medications. The average age of onset of hypertension in the multifocal type is age 40. There's a 10-year delay to the diagnosis of FMD. Only a third of these people get intervention because the longer you have hypertension, the less likely you're going to have a favorable response to intervention. And you don't need intervention on many of these people. Their blood pressures were normal on medication on a mean number of 2 blood pressure medications. So just because you have FMD of the renal arteries doesn't mean you need to do an angioplasty. Yes, if you're 25 and you recently were diagnosed, you should have a procedure done. Why should you have to take medicine for your whole life? But if you're 50 or 60 or 70, there's no reason to consider a procedure unless you can't control the blood pressure. My junior colleague is the first author on this paper, Dissection and Aneurysm in Patients with Fibromuscular Dysplasia. This was when we had 966 patients. Here's an example of multiple renal artery aneurysms. And 22% in the series had aneurysms, the most common place being the renal arteries, followed by the carotid arteries and intracranial arteries. But really, it could be any artery, including the aorta. This is a patient I've been following for about 12 years with these bilobed basilar artery aneurysms, which we've been following. And this woman is a nurse who had this small aneurysm in this area of tortuosity, and she's had 2 pregnancies that have gone uneventful without doing anything. Here's an example of a carotid dissection with a pseudoaneurysm pre and post intervention. And then dissections occur in 26%. Now, not all centers were doing head to pelvis imaging then. In our center, 35% of patients have had a dissection and about 30% have an aneurysm somewhere. So the most common place for a dissection is the carotid arteries or vertebral artery. It's the vertebral artery here, followed by coronary arteries. When we started this, we weren't even looking at SCAD. We didn't even know about the coexistence of SCAD. This number is going up every year. So SCAD, spontaneous coronary artery dissection, is part of the phenotypic presentation of fibromuscular dysplasia. And here is what you can see with ultrasound these days. This is called B-flow, and this is a method that allows you to see the beating in people with fibromuscular dysplasia. The base of the skull is here. This is where the carotid artery enters the petrous bone. So we can get up pretty high and see pretty well if we look. So 42% of all patients in this 966 patient series had an aneurysm or a dissection in some arterial bed. So this leads to the recommendation that everybody be fully imaged. Now we're going to update this to our 2023 data, but look here, this is dissection, 19.7% in our first paper, 31% in our updated series. In this first paper, we weren't imaging everyone. In this paper, more and more people were being imaged from the head to their pelvis. So in the consensus document, this was a point of consensus, regardless of the initial site of vascular bed involvement. Patients with FMD should undergo imaging of all vessels from the brain to the pelvis at least one time, and usually with CTA to identify other areas of FMD, as well as to screen for occult aneurysms and dissections. Now, we also put or contrast-induced MRA. I'm changing my mind on this because I've seen a few cases now. I saw a patient a few weeks ago. We did an MRA in 2014. It was normal. A CTA was done 2 years later, and she had extensive beating of the renal arteries that was totally missed on the MRA. MRA can miss very mild fibromuscular dysplasia, and it can miss smaller aneurysms. So if there's no contraindication, a CTA is best. We do it as 2 exams, a CTA of the neck and head, a week or 2 later, chest, abdomen, and pelvis. Some people do it as one exam where they do two injections. Remember, blood's flowing in two different directions, but you never get quite as good of a study. So we try to do it as two exams. But once we get everybody doing this, I think you're going to see the aneurysm rate be about 30, 35%, the dissection rate about 30, 35%. Now, there are some non-syndromic arteriopathies. Okay, we talked about FMD. What about this condition, segmental arterial medialysis? This is a disease that affects the visceral circulation with dissections and aneurysms. There's only one way to make this diagnosis, and that's histopathologically. If you see a radiographic report that the patient has segmental medial arterial lysis, you know that that has to be possibly wrong because there's a specific vascular pathology that occurs. It's vascular degeneration of the arterial media. It is not FMD, and there's no way to diagnose it radiographically, yet there are studies in the literature where they've tried to diagnose this radiographically. And then we have a thing called FMD-like arteriopathy. And what that means is they have everything an FMD patient has, but they don't have the string of beads. So I'll tell you more about that in a minute. I'm not going to talk about SCAD in any detail other than a large number of patients with SCAD either have FMD or they have vascular, extracoronary vascular abnormalities such as tortuosity, aneurysms, ectasias, or dissections. I'm going to skip that. Whenever you see in any artery, normal artery, this happens to be at a hinge point where a lot of coronary dissections occur, long, smooth, narrowing, normal artery, that's dissection. I don't care what artery it's in. That's a clinical clue. When it comes back to being a normal artery, that tells you you're dealing with a dissection. You don't see a dissection flap here because this is probably intramural hematoma. But this is what dissection or intramural hematoma would look like. A consensus point from the International Consensus document, regardless of the initial site, that any patient who has FMD or SCAD should have head to pelvis imaging. So if you see a patient with SCAD, they need to have CTA of the neck and head, chest, abdomen, and pelvis. The primary manifestation of SCAD is at the time it's happening. Doing a stress test will not predict SCAD. Doing a heart cath will not predict SCAD. So if the patient has it and they have no intervention done, there's no point in doing a stress test later on down the line, unless obviously they're having chest pain. Jackie Saul from Vancouver showed very nicely, angiographically, that virtually all of these SCAD patients heal. If the artery is not cut off completely, virtually every patient heals the SCAD within a very short period of time, a week or 2 weeks. Now, I just want to mention a few misconceptions. That you can tell how severely narrow an artery is by looking at the angiogram. That you can tell how effective your angioplasty is by visual inspection. And that because the norm for atherosclerotic renal artery disease is to put stents in, that's the norm for FMD. So I show you 4 angiograms here. Which one is the most severe? When you see somebody saying that there's a 70 or 80% stenosis, you know they don't understand this disease. To me, this looks like the mildest, right down here. So any patient who's going to have an intervention needs a pressure wire, and you need to do simultaneous pressures between the aorta and the distal renal artery. And actually, this is the most severe pressure gradient-wise, and this is the least severe, which looks the most severe to me. So you do it before the angioplasty and you do it after the angioplasty. And if you don't obliterate the pressure gradient, then you have not adequately taken care of the patient. So anybody doing an intervention needs to do pressure gradients before and after angioplasty to make sure the patient is adequately taken care of. Now, this will show you don't really need OCT for what you're seeing on the angiogram here, but I want to show you something here. Many of you are familiar with OCT. Here's the catheter. You're going to see little webs coming out. as we go. You're going to see the artery get bigger and get smaller. And you're going to see towards the end that there's a dissection in the artery right there. So let me just play this for you. Okay, we just saw a web come out there. The artery's big, big dilated artery. It's going to narrow down. You see all the webs coming out. Artery is going to get smaller. Look how narrow that is. That's this part here. And it's going to get bigger. You're going to see dissection right there. You would have never picked that dissection up. We don't do this on everybody, but it helped us understand exactly what's going on in the artery, this renal artery of a patient with FMD. We'd never do this in a carotid artery. Now, the other thing about this is you can't just go by visualization. This is a 26-year-old. I saw her over a decade ago. Blood pressure 220 over 120. She had a really good cardiologist who screened her for renal artery disease within 3 months of the onset of hypertension. And you can see here this tubular narrowing here. And this artery looks pretty normal. And so she underwent angioplasty. Now, if we stopped there, we would have thought her blood pressure would not have been cured, and we would have thought that it just wasn't being mediated by this renal artery lesion, because this looks pretty normal. But we do pressure gradients on everyone, even when the artery looks normal. Now, here's an example. So the guiding catheter is here, the pressure wires across. Now you see this lesion there. We could not see that either on ultrasound or on angiogram. And the pressure gradient was 50 millimeters of mercury. So had we not identified this, we would not have done an angioplasty, and her blood pressure probably would not have been helped. She has been blood pressure medicine free now for over a decade. So these focal FMDs need to be diagnosed early, and they need to be treated where you obliterate the pressure gradient completely. Now, you want to avoid stenting for several reasons. This is the entire renal artery is stented here. And you have a stent fracture in the distal end of the stent here. So remember, as the patient breathes, the kidney goes up and down and it rotates. So it's constantly doing that. It puts enormous torque on this part of the stent. So you don't put a stent in for FMD because you don't need to. And because FMD extends all the way out to the most distal part of the artery where you end up with stent fractures. And now if the patient has to go to surgery, you've made the surgical operation much more difficult. There are times when you have to put a stent in. If you cause a dissection, you have to put a stent in. But you want to try to avoid it if you can. Now, in the last part of this, I want to just talk about a couple of other manifestations. This is an example of arterial tortuosity. Yes, there are many genetic diseases that have arterial tortuosity. There are certain conditions that don't have names that have arterial tortuosity. Arterial elongation increases with age. And I see on radiological reports and sometimes on cardiac cath reports that the arteries are tortuous due to long-standing hypertension. And that's not true. This tortuosity occurs because of a defect in the collagen of the arterial wall. So anecdotally, we noted in FMD patients that they had tortuous arteries, yet it had never really been studied. So this is the kind of thing we would see. This is color duplex ultrasound. The feet are to the right, the head is to the left. You see this S curve. And this is what her carotid artery looked like. She's a physician. She had a dissection of her left internal carotid artery and had a non-disabling stroke. And this is what her right internal carotid artery looks like. Remember, the bifurcation is here at the angle of the jaw. So this is up pretty high. So we decided to look at this in a formal way. And we came up with this paper, the S curve. Sanjam was our internal medicine resident at the time. He thinks this is named after him, but it's really not. It's named after the shape of the artery. The S curve a novel morphological finding in the internal carotid artery in patients with fibromuscular dysplasia. So we took 100, now this is entirely a vascular lab study. We don't know anything about these people clinically, except for the ones who had FMD. 34% had an S-curve. Control group 1 was age and sex matched. They're all sex matched. So the same age, 2 of 74 had an S-curve, and we don't even know that these 2 didn't have FMD. All we know is they were the same age and they had an S-curve and they had not previously been diagnosed with FMD. And then control group number 2, 16% had an S-curve. These are people age 70 and above. So we tell our vascular techs, if you have somebody over the age of 70 and they have arterial tortuosity, just describe it as arterial tortuosity. Don't put S-curve in the report. It may be a normal finding for somebody who's over the age of 70. There are other areas of tortuosity. This is extreme arterial tortuosity that you get. You usually see this degree of tortuosity in diseases like Loeys-Dietz, Marfan's, vascular Ehlers-Danlos. But you can see this degree of tortuosity in those with FMD. Here's where the aorta bifurcates at the area of the belly button, and you can see the iliac arteries here. So I want to just differentiate FMD from FMD-like, and I think they're going to end up genetically being the same. FMD, you have to have a string of beads or a focal or concentric or tubular stenosis. And then these other things, dissections, ectasias, aneurysms, and tortuosity can occur in FMD, but they can occur in a whole host of other conditions as well. FMD-like is FMD-like is you have these other conditions, but you don't have the string of beads or the focal stenosis. Now, I'll show you how these other conditions can sometimes confuse you. And I wrote this editorial called Expanding the Clinical Phenotype of Fibromuscular Dysplasia. Let me just skip that and get to what I call the 3 sisters. Now, I have a bunch of families like this. Sister 1 is who I saw first. She had really tortuous arteries and a left splenic artery aneurysm, which you see here and here. Sister 2 had multifocal FMD of the internal carotid arteries, of the right renal, and left accessory renal, and of the right internal and external iliac artery. And sister 3 had bilateral internal carotid arteries, spontaneous coronary artery dissection, and mild dilation of the celiac artery. Now, are you telling me that sister 1 doesn't have FMD? Of course she does. She just doesn't have the phenotypic expression of FMD in which you have the string of beads. So according to the way our registry is set up, we can enter the first sister 2 and 3 in the registry, but we can't put sister 1 in our registry because she doesn't have the string of beads. But we can put her into our genetic study, which is what we're doing, to try and sort this out from a genetic basis. I'm going to skip carotid dissections. And I just want to bring up genetically, Stephanie DeBet, who runs the Carotid and Vertebral Dissection Registry, CASDIP Registry in Paris, identified this gene locus called PRACTA1 is associated with susceptibility for cervical artery dissections. We published this paper with the group from France and Belgium on PRACTA1 is a genetic susceptibility locus for fibromuscular dysplasia, supporting its complex genetic pattern of inheritance. And David Adlin and the group, our group and the group from Paris and Belgium and Poland published this common genetic variant in PRACTA1, EDN1 locus is associated with spontaneous coronary artery dissections. These are all genetically interrelated. That these 4 conditions are increased levels or increase the likelihood of these conditions. Lower levels increase the likelihood of these conditions. And I want to just finish with our DEFINE trial. we take a piece of skin from the back of the arm and we grow these fibroblasts. This is skin here. This is Valentina, who brought her best friend in to be a normal, healthy control, and her best friend ended up having fibromuscular dysplasia. So this is a little outdated, but we have 400 patients, 209 FMDs, 231 controls. The first paper to come out of this study was this, published in the European Journal of Cardiology, on a plasma proteogenomic signature for FMD, in which we're attempting to develop a blood test that will identify people who have FMD. We're about 70% there. It's not ready for prime time. And I don't have time to really go into the details of that. And I just want to finish with this slide. I would consider FMD diagnosis under the following conditions: onset of hypertension at a young age, resistant or difficult to control hypertension, anyone with an epigastric bruit and high blood pressure, a cervical bruit in someone under the age of 60, anyone with pulsatile tinnitus, severe and recurrent headaches of the migraine type. Now, I'm not suggesting that everybody with migraine headaches be screened for FMD, but I am suggesting if you have severe migraines, you would at least need an MRA and an MRI of the head. And if you have any of these other conditions, it should increase your likelihood that you may be dealing with FMD. TIA or stroke at a young age, anyone with a dissection of a peripheral or coronary artery, aneurysms in visceral or intracranial vessels, aortic aneurysms in young people, subarachnoid hemorrhage, renal infarction. So I just want to finish with none of this would be possible without the FMD Society of America funding the FMD registry. They pay for the University of Michigan to be our data coordinating center. This is when we were in Belgium at an international FMD consensus conference. This is these are my colleagues. Jason is an MD PhD who runs my DEFINE trial, Pam Mace, and several of our other colleagues. This is our entire team at Mount Sinai. And of course, none of this would be possible without these two women and the many, many, many other patients with FMD who have done everything they can to increase awareness of this disease among the medical community. So I'll stop there. I'm happy to answer any questions or hear any comments that you have.